Hi, this is Dr. Mike Stoner bringing this month, June 2020's MEC Minute. And today we're going to talk about pediatric strokes. There was a request for some pediatric stroke lectures, so here we go. All right, so I guess to start off with, you guys see a lot more strokes in adults than kids. And what is a stroke? It's a lack of perfusion or blood flow to one particular part of the brain, causing decreased function and some injury. So my intro is that we do predominantly see these in adults with atherosclerotic disease. Rarely do we see them in kids, and because we rarely see them in kids, many times the presentation is delayed. People are not thinking about them. And by not thinking about them and not recognizing them, about 2/3 of kids who have a stroke will have some persistent deficits after the fact, unfortunately. All right, so our objectives today, we're going to discuss the basics of pediatric strokes, compare similarities and differences with adults, and then the acute management of pediatric strokes. All right, so let's touch base on some epidemiology. First off, in the perinatal period, we see about 1 in 3,000 live births will end up having some type of stroke. That's much more common than pediatrics. In the childhood period, which we say is about 2 years to 17 years, just under 18 years, the literature kind of varies a little bit, but all very small, up to 1 to 4 per 100,000 children will end up having a stroke, and that doesn't include the ones we just talked about as infants. They're more common in males. Ooh, for us guys. They're also more common in the Black population, the Asian population, and likely due to some genetic risk factors. And then overall, in the whole United States, we'll see about 5,000 strokes every year in kids. So similar to the adult population, strokes come in 3 flavors. Our 2 major flavors are hemorrhagic, or some kind of bleeding into the brain, and ischemic, some kind of lack of perfusion to the brain. Then we also run into some cerebral sinus venous thrombosis. All right, let's start with hemorrhagic stroke. So in order to be considered a stroke, it cannot be traumatic. Traumatic injury that ends up in a head bleed is not considered a stroke. In the pediatric population, we have about equal amounts of hemorrhagic stroke as ischemic strokes, which is different than the adult population, which are mostly ischemic strokes. We do see a higher mortality with the hemorrhagic strokes than their counterparts, and mostly arteriovenous malformations is probably the biggest cause of the hemorrhagic stroke. Having an AV malformation, which unfortunately will rupture and then cause a bleeding to an area. Other causes, some kind of cavernous malformation, some type of aneurysm, or a tumor. For our ischemic category of strokes, there's some arteropathies. There are, which I spelled incorrectly, there are cardiogenic strokes, prothrombotic states. Your body likes to clot, and you'll have a stroke, and then some type of systemic disorder. We'll start with arteropathies. Approximately 50% of all ischemic strokes are because of some issue with the vessel. And these are all vessel issues or arterial issues. There could be some kind of structural abnormality of the vessel. Excuse me. In the cerebral or cervical or intracranial artery. Stenosis or a big narrowing of the vessel will cause a decreased blood flow. Some type of aneurysm can cause decreased blood flow. I mentioned here moya, which is, I think it's Japanese for puffs of smoke. We see it more in our Asian population, also see it in our sickle cell population. What happens is you'll get kind of dilated areas because of poor perfusion, so your body makes collaterals, and if you do an arteriogram, it looks like puffs of smoke. Other reasons to have vessel issues are dissection, and then finally occlusion of some sort or another, not embolic in nature. If you do find one of these in children, let's say a a child is getting a head CT for some other issue, they bang their head, who knows, and they find that they had some kind of arteropathy, they need to take care of it because they have a 66% chance of ending up having a stroke over the next 5 years. Okay, so let's talk about the other reasons to have a ischemic stroke. So, like I said, something wrong with your artery accounts for 50% of your strokes. Cardiac, starting at cardiogenic, accounts for another 30% of pediatric strokes. This could be some kind of congenital heart disease causing a thrombus to form and then break off into your system. If somebody has the some kind of right to left shunt, they have a more likely chance of this happening. And again, that goes back to some kind of congenital heart issue. The next category, prothrombotic states. So, let's say somebody has a bleeding disorder where they are hypercoagulable. They can have an increased risk of clotting, and usually it's not. I mean, they live with that. That's their daily life. They have this hypercoagulable state, but then something else hits on top of it. They get sick, or they have a trauma, or something, and it just pushes them over the edge to clot off and cause an occlusion and then some ischemia. The reason this is important is because it's modifiable, right? There's if you know you have some state where you're going to clot a lot, you try to find a way to prevent that. So if you do have that illness or that injury that pushes you over the edge, then you're not as at risk because you've modified that. Lastly, in our causes are systemic disorders. So, if you get sepsis is a big one. If you are receiving methotrexate intrathecal through a lumbar puncture, you are at increased risk of getting a stroke, and then certain genetic disorders are also increase your risk. The last category that I kind of put off to itself is sinus venous thrombosis. Some type of an issue, or we'll just say issue, the cerebral sinus vein. The reason I say issue is because it can be ischemic or it can be hemorrhagic. A lot of times we'll see kids come in and we'll find out later that they had some kind of thrombosis in their cerebral sinus vein, but it can also be hemorrhagic as well. It's rare, not very common. Etiologies that cause it: recent surgeries, some kind of prothrombotic condition like I just mentioned, a medical problem that causes you to be prothrombotic, or if you're on a medication that can also cause you to clot easily. And then severe dehydration can be a last part of that category. So we talked a little bit about the nuts and bolts. These are the what a stroke is, what causes them, and what are their categories. So great. And a lot of that's not terribly different from adults. Maybe the epidemiology is, but then how do kids present? Motor issues are probably the biggest one. Hemiparesis, or weakness on one half of the body. You'll also see some speech or language disturbances, vision disturbances, some wobbly gait or ataxia. Headaches are probably more common in kids than adults. Excuse me. Altered mental status, and in seizures. I made this one red because under 6 doesn't mean kids under 6 can't have seizures, but we do see a lot of seizures. Some of those could be the first sign of a stroke. So because we see a lot of seizures, just keep in mind that it may be something more than your typical febrile seizure or something else. And then finally, posterior circulation strokes or decreased perfusion in posterior circulation usually present with headache, vomiting, and altered mental status. Couple caveats. We have a lot of adult screening tools. There's a lot of adult screening tools out there, and their sensitivity, it's only about 60% for detecting a pediatric stroke. So you can't just take an adult tool and put it on the kids. One of the presenting signs of a stroke, like I said, it can be some speech disturbances, and a lot of times it's stuttering, and in kids that's probably more common to present with stuttering than in the adult population. Headaches, I already mentioned this. Children are more likely to have headaches and seizures with acute strokes than adults. So this may be a first presenting sign. And then I guess also lots of kids come in with altered mental status, altered behavior, altered motor sensation, but there are a lot of mimics in kids, and they are much more common than true strokes in the pediatric population. What are those mimics? Todd's paralysis. That's usually a unilateral paralysis after a seizure. Bell's palsy, a weakness of the forehead, that can be caused by a few viruses, Lyme disease. There's a lot of different things that will cause that. Hypoglycemia can cause it. Complex migraine, this is probably a huge one. People come in with, I lost vision in this eye, or I'm weak on one side, or various things, and it can be a complex migraine. Toxins, we see kids take things. Psychogenic, I feel like I've been seeing a lot more psychogenic things. I have here conversion disorder, which is probably an old term, still used, but the new lingo uses the term FND, functional neurological deficit. So it's a neurological deficit, but it's functional, meaning that it's psychogenic and not some other problem with the body. Brain tumors, vestibular syndrome, demyelinating diseases, and then traumatic brain injuries are all other mimics. So, why is diagnosis important? Well, it's not uncommon. And so like it says here, the first step to faster diagnosis is to think about it. And I think that's why I'm going to probably say that 3 times during this whole lecture, is you have to think about it. Looking at some of the data, about 10% of kids with ischemic strokes have had a previous visit for some type of missed stroke or missed TIA. If you look at our protocol, the MEC protocol, we use the LAM score. It's a good score. It's validated to predict stroke severity. It's used to predict some large vessel occlusion, and it is really easy and simple. It works on 3 different components, all motor components: your facial droop, your arm drift, and your grip strength. In pediatrics, I was looking through some of the literature, and it hasn't been validated and doesn't really work great in the pediatric population. At Nationwide Children's, we use BFAST. Again, it's a quick screening tool. It's not the gold standard. We'll get to that in a second, but the BFAST, so balance, trouble with balance, eyes, any kind of vision issues, facial droop, we talked about, arms, some kind of a drift and strength in arms, and then some speech issues, slurring of the speech, inability to speak, and then the T is for time. Time to treatment, time to get to the hospital, write the time down that it happened, so we can kind of tell when symptoms started. So last time to normal, that kind of thing. If we want to talk about gold standards, there is the U.S. NIH National Institute of Health Stroke Scale. It's a very long questionnaire, asks many different details. I did not put a link to it here, but easy to Google if interested, but it's not pediatric specific. So smart people said, hey, we need a pediatric specific one. So there's the PEDS NIH Stroke Scale. It too is many, many questions, but it's been adapted for kids age 2 to 17 years of age. And by adapting it, they account for some developmental issues. A 2-year-old is not going to be able to follow as many commands as a 17-year-old. So it does get adapted for the developmental level. It's calculated very similar to the adult version, the NIH Stroke Scale, where a high score means worse illness, but again, just specified for pediatrics. All right. So we talked a little about scoring the patient to see, how bad is your or what's the likelihood of having a stroke. But ABCs win. So if you're doing you come up on a child and you're afraid they're having a stroke, but they're not breathing, ABCs win. So if you have to take the airway, please do. Make sure that if the child's unable to handle secretions, if he's unable to maintain his airway, an aspiration risk, then we do what we need to do in the field. But if we do have to do that, hopefully we do not, but if we do, then it's good to know a baseline. So evaluate, motor response in all 4 extremities, and also level of mental responsiveness. All right, so what do? So we figured out, we're worried about it. If you look in the background, pediatric stroke awareness, again, thinking about it, first step. we want to be normotensive, so avoid any kind of hypotension or hypertension. I'm trying to keep our vitals as normal as possible. We do know that our body doesn't regulate quite as well during an acute stroke. And studies have shown that, if we don't keep our blood pressure kind of normalized in the first 24 hours, they may have worse outcomes down the road. And avoid fever. A lot of people have, about a third of kids will have fevers in the first few hours. So avoiding that so they don't have any issues. Again, they have trouble auto-regulating, and we don't want to cook them. There's been some studies looking ahead of bed. So we tell you, if you're worried about increased ICP, raise the head of bed, decrease cerebral perfusion so your ICPs aren't so high, or aspiration. But if you're not worried about ICPs, then a study in neurology is looking at that very essence, that very issue. And they said, you get a 20% increase in cerebral blood flow in an acute stroke patient when the bed is lowered from that 30 degrees, put it flat. And in the stroke issue, more blood is better. This is something that's right off the start from your protocol. I probably had the slide a little bit earlier, but normalizing the glucose. Checking glucose is very early because hypoglycemia can be a mimic of stroke. So if you are hypoglycemic, you want to find that and fix it. It can also make things worse. So again, find it and fix it. Make them NPO. We don't feed people in the back of the truck very often, but I've had some parents who think their kid's going to die if they don't eat every 5 minutes. So don't let them eat. We may need to sedate them for a study. We need to sedate them for their MRI, or they may be at risk of aspiration, so not protect their airway. So reasons not to feed. And then give them fluids. Treat their dehydration. If they're dehydrated, that can make things worse. So treating that. All right, you picked them up. You brought them in. What are we going to do about them? So we'll kind of take a step by step. We'll start with the ischemic strokes because they're more common in the adult population, about 50-50 in the kids. But we'll start here. Our tools in our toolbox. We have thrombolytics, or things to break the clot up, and then we have mechanical thrombectomy, take the clot out. Taking the clot out is not really routinely recommended. It's only if there is some type of an extra recommendation, is how the papers read. We've had some good outcomes, but not standard of care yet. And sickle cell disease is its own little entity, so we'll touch on that in a few minutes. All right, so thrombectomy. How do you thrombolysis. How do you break that clot up? So TPA, very standard adult population. In kids, they actually have a lower fibrinolytic activity than adults. So it's not yet standard of care. Do we use it? Yes. But the studies aren't there quite yet to say, hey, this is standard of care. As I mentioned here, there's been some case reports talking about it. A lot of them went out, and the time to drug wasn't standardized. One of them, we just didn't have enough strokes to study, and that's the problem. I guess it's a good problem to have. There's not a lot of illness to study it, but it makes it hard to treat if we don't have a lot to study. So we do extrapolate a lot of the information from the adult population. So what does NCH, Nationwide Children's, do for their for thrombolysis? So let's say we find a big thrombus, we want to get rid of it. So if we know it's within 4 hours, so that's why that T, or time, is important, and their deficit is not improving, they still have a PEDS NIH stroke scale of 4 or more, then they are a candidate for and they have neuroimaging to say they have an ischemic stroke, acute ischemic stroke. They find the clot, I just mentioned that. Then they're a candidate for thrombolysis. If there's a huge deficit, and it's in a large vessel, then they can consider going to the next step of taking. And we'll touch on that in a second here. So what are our guys? When do we not do it? What are our exclusions? If it's been over 4.5 hours, they don't fit criteria. If they're getting better, why fix it if it's fixing itself? If it's pretty mild, if they're really bad, sometimes we'll go a different route. If they're bleeding, obviously you don't want to give something to get rid of the blood, or to break it up if they're already bleeding. some of the illnesses due to an illness. We don't want to do that. If they've had a stroke or major head trauma in the past 3 months, you don't want to cause more problems. If they have reasons that they may bleed, a tumor, an arteriovenous malformation, prior head bleed recently. Actually, no, any prior head bleed. If you're going to do an arterial puncture, you're going to poke the artery and you're afraid it's going to bleed and not going to stop, or an LP within the last 7 days. And just some other ones, bleeding problems, pregnancy, and if you look like you're having, it's in the MCA, medial cerebral artery territory. So that's TPA or thrombolysis. When do you go in and go fishing? When do you take it out? So there are certain embolic or thrombolytic things that are just unlikely to respond to TPA. So if you have that, children must be bigger than 40 kilos. We don't do it in the really young ones. And then their Rankin scale or long-term issues have to be low. Exclusion criteria for thrombectomy. If you think they're going to pass away within 90 days, they don't go in and do that. If they have a cerebral hemorrhage, they won't go in there. If they have a bleeding problem, low platelets, or obviously, I said the weight has to be above 40, so if it's under 40, they don't do it. Kind of wrapping things up now. We've talked about, we found a clot. We can break it up. We can take it out. The other type of ischemic disease is going to be sickle cell disease, and because hemoglobin S, the sickle hemoglobin, tends to bind to itself and clot, and that's why you have your vaso-occlusive crises, why they have their pain crises. So the treatment for those, the first treatment if they have sickle cell disease, is not some of the other modalities we talked about, but transfuse them. You want to have a higher percentage of your normal hemoglobin than your hemoglobin S. So transfuse them up to 10 to 11 grams per deciliter. The ultimate thing is to do an exchange transfusion, kind of exchanging that hemoglobin S, sickle hemoglobin, for normal hemoglobin. Not as rapid, which is why you'll start with a transfusion if it's lower. So those are all the ischemic ones. Now let's talk about hemorrhagic. So what if you find a head bleed? Child comes in, headache, and then passes out, and we do our quick MRI and find they have an arteriovenous malformation that is ruptured, and now they have hemorrhagic stroke. So our treatments, keep them normotensive. Try not to get their blood pressure too low. You want perfusion, or too high. You want to make sure there's not too much pressure in your head. Same as the other strokes. Prevent hypoxia, prevent hypoglycemia. In this case, you are bleeding, so you don't want more perfusion, so you will elevate the head of bed 30 degrees to decrease your ICP. And then if they are in anticoagulation, you want to reverse that if possible. And then call somebody who can, to get into their head, we call neurosurgery. And I think that's about all I have on pediatric strokes. Like I said, not terribly common. At Nationwide Children's, we do have our S&D, as I talked about, our sudden neurological deterioration. They will come in, and if it's via EMS, or even if the parent walks to the door, and there's a concern, they get that BFAST exam by the nurse. And if there's a concern, they immediately call an attending physician to come and do a neuro huddle. And we do the Peds NIH stroke scale, and they get a what they call a S&D warning or alert. And so one of them gets you the warning gets you a neurologist and an MRI very quickly. And the alert gives you a lot of other people on call notifying it. So it gets the ball rolling, it gets the kids seeing, gets some image, and then gets the sound read. Similar to stroke alerts at other hospitals. We just want to call it something different. I think that's about all I have to say about pediatric strokes. As always, if there are any questions, don't hesitate to reach out and ask me. And I will be seeing you guys around. Thank you very much.